Thank you so much for having me here today. So we're going to switch gears a little bit and make this more interactive, as Mark has just said. And I thank so much Dr. Small and Dr. Page, who have set up the stage so nicely for this next talk, because we've learned a lot now already about some of the plant basics, and so I think that'll help us along. I've got a couple of friends with me here who are going to help us through the cases, and we may draw on some of the audiences I've mentioned. There's about 7 cases, and we're going to be looking at the relationship between the plant and the clinical outcome. So I do have some disclosures. I'm working with a few different companies, and I've done some lectures and received some grants. And then, same slide as John, in terms of mitigating potential bias, I wasn't involved in the planning committee, and the content was reviewed by the steering committee. So this first case here, Dr. Smalls actually alluded to it a little bit in terms of talking about CBD and sedation. So let's just go through it. And we can tease out some salient points. So this is a 40-year-old male who presented with anxiety and insomnia. Previously, no other notable medical history, and he had tried everything he could possibly think of and had tried CBT and done sleep studies and various appropriate measures. And so he wanted to start on some CBD, and he found that he was quite fatigued throughout the daytime. And he was surprised by that. And so he actually ended up using it just for nighttime for sleep. And so before I move on to some questions we can speak about surrounding this case, I just wanted to remind us all, because I'm not sure if everybody's aware, so when we use the word psychoactivity, that actually applies to both CBD and THC. So both of these substances are psychoactive. That means it crosses the blood-brain barrier and has an effect on the brain. However, we frequently then talk about intoxication. So CBD is non-intoxicating, whereas THC may be intoxicating, dose-dependent, of course. And with intoxication can also come euphoria. Those terms can be used together. So it's important to realize that CBD does have psychoactivity. And certainly I did a medical legal in the past year, and impairment in the workplace, these terms come up, and this is going to be more relevant going forward, in that some people think, oh, CBD, there's no problems with it. That's what we'll use in the daytime to avoid using THC, and we really do need some more information in this area for sure. So I guess turning maybe to John, first of all, some questions such as, the sedation that this patient is observing. Is this CBD? Is this myrcene? Is it terpenes? And some patients say CBD stimulating. What may that be?
Yeah, are these mics on? Yeah. Actually, good point about psychoactivity. I mean, I've been guilty of saying CBD is non-psychoactive. That was my sort of go-to term, and I think Caroline quite rightly says it really should be non-intoxicating. A question, Caroline, about this. This is an oil product that this person is consuming?
Sorry, it was an oil for ingestion.
Right. So, I mean, one of the things, and this goes back to my last point, that we need more research, the idea that, is CBD sedating per se? I don't think there's a lot of evidence for that in terms of the pharmacology. So, but people respond to the different molecules differently. So there could be that. In terms of the sort of terpene side, I mean, we do have a kind of sort of pattern emerging that myrcene, and Ernie indicated myrcene is the driver of this sort of sedating properties of humulus, or the hop plant. So myrcene is also thought to be potentially present in higher levels in sort of indica type plants, therefore suggesting that they may be more sedative because of that particular compound. The issue here, I think, in terms of the research, is that we don't know with oral ingestion what's happening with terpenes. Certainly we have PK data, et cetera, on cannabinoids via smoked, vaped, and ingested, and IV, et cetera. But myrcene, I haven't seen the studies that would suggest, is it rapidly absorbed? Is it, how fast is it metabolized by the liver? Is there any breakdown by, microbes in the gut, for example? So I would hesitate with an oil and ingestion to sort of say, oh yeah, that's obvious, it's myrcene, that's why the sedation is occurring. So that would just be my sort of first principles take on that.
That's super helpful. Daniel, what do you think?
So the oil that they were using, was it specifically high in myrcene, or was it just a generic CBD oil?
Yeah, great point. So lots of the licensed producers have different ways of presenting their oils online. So some of them you can see full terpene profiles, and they nicely characterize the top 10 to 15 terpenes they may have. And then others are pretty much just generic, and it's really only speaking to the major players. So it was CBD drops or CBD, predominant, didn't really mention all the other or even the other cannabinoids.
Yeah, because what we find also in clinical practice is there can sometimes be a difference in response, whether it's a CBD oil that is pure CBD or if it has terpenes added back in.
Yeah.
So that was my first question and thought around this. And the other question is maybe terpenes don't even matter when we're talking about CBD because of the potential effects that CBD can have on the FA inhibition, and is it just boosting the body's own endogenous cannabinoid tone, allowing us to go back to normal homeostasis, allowing someone to sleep?
Right. And then another thought that we kind of had in the clinic was if somebody's in for this patient, not so much they're having anxiety, well, maybe even still, but people in pain, if you're actually getting some pain relief and you can maybe finally settle a little, well, maybe that's been overwhelming and very fatigue provoking. So it's really hard to really tease out exactly what is what. Yeah. But in the interest of time, we'll move on and we'll take some questions at the end. Oh, sorry.
Can I ask a
Go
question?
ahead. Yeah, sure.
There's been some story in the literature recently about oral CBD being converted into THC in the gut.
Yes.
And I wonder if someone's taking an oral CBD oil,
Right.
has this controversy? I know that there's been a lot of argument that it's not at the right levels, but since it's out there, can I ask the
Right.
panel to address that question?
So-
Are we clear on this?
So the paper that I'm aware of was using, so it was not in humans necessarily, and the pH of the stomach acid was not the same. I'm looking around just to make sure was certainly different than human kinetics, and so I don't necessarily know that would happen in vitro in vivo the same way if it was more simulated.
Yeah, I think it's been fairly conclusively refuted that particular experiment. But I'm just looking back at Hanan behind you, Mark. Can you give Hanan the mic, because he's going to. I think it's worth spending a bit of time on this, because this concern is also relevant to things like drug testing, the future of NHP type products that will potentially be only CBD and no THC, and if we're seeing conversion in the gut or otherwise, I think it's important. Sorry to put you on the spot.
There you go.
There we go. Okay. I'm not sure how much more I have to add to the conversation, because I know that paper that came out a couple of years ago was very controversial. It generated a lot of sort of back and forth in the journal. And it wasn't just the conversion of CBD to THC, it was the conversion of CBD to other hexanabinols, which other forms of a cannabinoid that might have psychoactive properties. But I think historically speaking, Rafi Meshulam actually showed 40 years ago that if you took CBD and added hydrochloric acid, you would get THC. So he showed that like 40 years ago, and that was just, HCl. I don't know what the pH in particular in the experiment was, but that's one way that you could convert CBD to THC. Now, whether that has, to what extent that happens in a real organism and how much of that gets absorbed and is an open question, I think. But there might be other pharmacological mechanisms by which CBD might potentially cause a sedative effect. Like I think Matt yesterday was saying, CBD has a lot of off-target targets, right? So it acts on the 5-HT1A receptor, it inhibits adenosine uptake, acts on GPR55, and a whole host of other molecular targets, which might somehow cause a sedative effect. So, just 2 cents worth.
Perfect.
If you keep answering that, well, you have to come back up.
Yeah, you can join. Okay, perfect. Let's move on to the second case. So this case, I may ask if Jonathan, he's in the back there. I may ask him to comment on this one just when I get to the end. So this is a 30-year-old with PTSD and history of other anxiety-related conditions. He's tried benzodiazepines, clonidine, propranolol, SSRIs. And so for him, this was actually an experienced user who came to me and had been self-medicating prior to us using medical cannabis, was using 2 to 3 grams a day. And sorry, I haven't been specifying if it was necessarily oil or dried product, but for the majority, I would say more than 90% of our patients in our clinic are using oils. Certainly a number of them do like vaporization, especially for acute onset symptoms. So he was also using some vaporized product, but using about 2 to 3 grams a day. And what he noted was that he needed to rotate among a number of strains, maybe 3 to 4 strains, or Chemovars. And he did so because he found that the effects would wear off after a few weeks, and he didn't want to go higher on the dose necessarily, but then when he tried another strain, he felt that it gave new relief, or the same relief. He was able to sustain that. And I don't know if I can maybe first go to John before I go over to Jonathan and see, but I know that I've heard patients say this before who've been experienced, so I don't know if there's any explanation about the plant in terms of what may be going on.
Yeah, I haven't encountered this sort of anecdotal issue, and I think Jonathan can talk about it briefly, but there could be, and maybe this is grasping and for straws a little bit, that if the THC levels are the same, and yet this rotation through is leading, if the terpenes would vary potentially between those different chemovars, and if the terpenes are contributing some of the activity or modifying the metabolism of cannabinoids or something, there could be a sort of a terpene tolerance thing.
Yeah.
Now, that's very speculative, I would say, but if there is an explanation, I think it might lie in that.
The terpenes. Okay.
And
Oh, sorry, go ahead.
Oh,
Yeah.
sorry. I just wanted to reinforce the fact that this is something that we see not only with cannabis, we also see with opioids.
Yeah, that's true.
When we have patients, chronic pain on chronic opioid use, we have opioid rotation when patients become tolerant. So in this way, it's very similar to other medications, and we have to remember that this is another reason why it's important to have various strains, cultivars, or whatever you want to call it, for our medical patients in order to reduce the cannabis burden that they require.
Perfect. That's such a great point. Thanks. Yeah, let's go.
Yeah, so I don't have too much more to add. I think you really covered the issue well. It is a quite anecdotal issue at this point where patients, including myself, report exactly what you said, which is you have a strain, and I think CBD as well, THC or CBD-rich strains, and find effective symptom relief, and then it stops working. So the option is either to go up in dose or to switch to another strain, and I think that's seemingly to be a possible better avenue because switching strains won't result in more THC,
Exactly.
but have the same effective symptom relief, hopefully.
Perfect.
So I don't know what's there. We're also hearing that this happens in the pediatric epilepsy population with CBD oil, and that makes me question also back to case 1, which is if there's terpenes in that CBD oil or not. And, I think it's a point to consider going forward in terms of a regulatory perspective as well, having more reporting requirements and testing requirements for terpenes so that we can have more standardization to study it would be helpful.
Yeah, perfect. Okay, great.
Yeah, I'll just add from the
Yeah.
perspective of an analytical lab, terpene analysis is not it's not a mandatory quality control part or testing part of the quality control system in the ACMPR. So lots of LPs do that because they are hearing conversations like this or wanting to differentiate their products, but it's not all of them. And also the manufacturing of the oil relies on decarboxylation, a heating step that drives off terpenes. So there's losses there as well. So it's a little bit of a black box in terms of what's available now.
Perfect. Okay. And so that takes us into our next case. This is actually 2 photos from a patient who was limited in income. And so these are CBD products that she was purchasing. And I actually hadn't really, looked that closely at the labels this concept of actual versus potential concentrations. So you can see the label on the right, the actual THC and the potential THC are the same, and the same for the CBD. However, the other LP product on the left, the THC content is pretty much the same, 1 versus 1.1, but you can, I can't read it from right here, but you can see there's quite, is it 16? 16 to, can you guys read it?
27.
16 to 27 in terms of the difference for the cannabidiol. So I found that very interesting because, you know, her point was, well, if I'm going to pay the same price for both products, well, I'm going to go with the product that has more actual containing in its in the bottle. So John and I were trying to go through this yesterday, and we've called a couple of other friends, and hopefully you can share what we found out.
Yeah, I think, so this actual and potential refers to the fact that in cannabis flower, where the cannabinoids are found as their acidic forms, and they haven't been decarboxylated to the bioactive neutral forms by heating, you know, through vaping or smoking, that the potential is the measurement of what's found in the plant, and the actual is the calculation to what that will yield when decarboxylation occurs. Now that's not relevant in oil products such as the one on our right, the white label, because you can see the numbers are exactly the same between actual and potential. Because the licensed producer is fully decarboxylated the cannabinoids before they produce the oil. The example on the left is a bit of it's a manufacturing issue. I don't know, do you want to briefly talk about this, Shane, or yes? Yeah, do you want to get to the mic just to? So I asked someone who knew more about this particular product, Shane Morris.
Yeah, so when I saw this, it's clearly, to me, straight off, it looks like one of two things. One, that the decarboxylation step in the oil production was not done fully. Or second, that it was done to a limited degree to allow a certain, limit, a targeted CBD level. I predict it's probably the first one, but you can decarb to certain levels. If you get your decarb process right down and dialed in, you can decarb, and so the actual active could be, the actual could be much more present in an oil. So if, for example, you could get a decarb, you could get, fresh product, flour, decarb it halfway, and then only have half a potent oil.
Yeah.
So that decarb process is an important process, but I predict here it's probably just the decarb process didn't go all the way. But I would note that on the front of it, it has to actually have the actual on it. So what you'll see, what the patient would buy on the website would actually be the actual.
The 16 or whatever it is here in this case. So this is I would say that, thanks Shane, this is a anomalous result. There's accuracy there. How are we doing with time? Can I just quickly give Daniel? If you can really go quickly here.
Thanks, John. THCA and CBDA are distinct molecules and have their own activity. So a few LPs sell a THCA oil, which is non-psychoactive, and some patients find it helpful for certain conditions. And similarly for CBDA, we learned at ICRS last year that it can be a really potent antiemetic. So you can actually have 4 molecules with just starting from THC or THCA and CBDA and have a lot of different mixtures. So it could be that a mixture of the CBDA and CBD then has a distinct activity.
Yeah, thanks. And thanks as well to people who represent LPs with not doing ads, as you guys just did. So that was good. Go
Yeah,
ahead.
and just one more point though, that patient wanted CBD only, wasn't necessarily interested in CBDA, even though, there's still certainly potential value there. And for her cost-wise, the price for that bottle was still the same regardless of what the actual yield was on that batch. So I just think it's an important consideration. Just batch to batch may have some variety. and I just had a couple more points, and I think we've gone through all these actually. It was, what is actual versus potential, and was it related to the extraction technique, and then Health Canada, what should be on the label, but Shane's already answered that for me, that the front label will be what is actually in there, not the potential, because there's cost implications, of course. So with the interest in time, I'm just trying to see which cases I should do, because the last one I really want to do, I'll do this one as well. So this one here is a THCA only responder. And so this is a 50-year-old female of mine I've followed for a number of years. She has chronic fatigue syndrome and a number of other central sensitization syndromes, such as irritable larynx and IBS. She's on methadone, and she's tried many other substances that she hasn't tolerated very well. And we've had her on over 12 different products, dried versus oils, more than 5 different licensed producers. We've tried indicas, sativas, everything you can imagine, and no response at all from any of them. And she tried THCA, and it actually really worked. But it only worked for 3 months, and then we lost the response. And so I guess I'm wondering, why would THCA work when THC versus CBD wouldn't, and why would you have a response and then lose the response, which I think we've touched a little bit on already. Jonathan?
Yeah, I think it's a difficult one to answer. I'll just say that as Daniel at the mic just said, CBDA and THCA, so the acidic cannabinoids, have their own distinct pharmacology, and Linda Parker at Guelph has done some really groundbreaking work on CBDA and THCA in anticipatory nausea and using some animal models there. So we can't just say categorically that it's all about the neutral forms, so THC and CBD, that the acidic forms of cannabinoids do have activities, but how to connect that with this particular chronic fatigue syndrome, I'm sort of at a loss, Daniel.
Same here. I'm at a loss. I think there's a tremendous amount of research that we still have to do in terms not only THC, CBD, but the acid forms as well. But I also want to address the fact that if they were using one specific product for a period of 3 months and then it stopped working, is it because it was a slightly different product from batch to batch? And that just speaks to the need for patients for standardization.
Yeah, fair enough. And we touched on this. Yeah.
So I have a question as well about this, because it's been clear in a number of circumstances that some physicians are authorizing extremely high doses of cannabis in the orders of hundreds of grams a day. And some of the justification for this is that they're buying fresh cannabis, not dried or oil, and juicing it to make, because of this THCA. Can we shed any light on this story? How much cannabis do you need to juice to get a therapeutic dose of THCA?
Yeah.
I know this is probably quite unusual and quite rare, but it does come up, and it's certainly medically very important.
Yeah, I mean, I have a patient who came wanting 20 grams a day exactly for that reason, and wanted to grow her own as well, because obviously it's cheaper when you're talking about that quantity. And there's no way for me to know if she's just using the leaves and juicing those and diverting the dried product for all the rest. So our rule in our clinic has pretty much been nothing more than 5 grams. That's just kind of where we've settled out. And I'm not saying there's not a very valid. She had some YouTube videos, she had an autoimmune condition, she wanted just the acidic form. We just didn't feel comfortable authorizing for that purpose of just using the acidic form. If she was using it for pain or whatever symptoms, THC and CBD are more potent and going to be able to achieve that easier. So we just couldn't justify it. It's a tough call though, because patients want access.
And your question was, how much plant matter will you need for a therapeutic dose of THCA? What's a therapeutic dose?
Okay, more research, right?
I would say too that I don't think any of the licensed producers are currently providing fresh cannabis. So I think they're able to quickly.
Floor around the outside of the room right now, so if any of them have an answer. Are any of you guys shipping fresh cannabis?
So the problem with fresh cannabis, no one's doing it because it's impossible to meet the GPP requirements, and I have tried. So it was a regulatory change to Plymouth at Supreme Court to be able to say in front of the Crown, "Oh, Your Honor, we have fresh oils, dried, etc." It is not possible to meet the GPP requirements as currently outlined with fresh currently.
Right. So this is generally, if patients want this, they have to grow it themselves.
Grow their own,
Yeah,
yeah.
but the dose thing, I think, is totally unclear, as Daniel's mentioned.
Yeah. Okay, so in the interest of time, I'm going to skip over the next two, and we're going to just do the last case, which Mark asked me to include. I can provide, well, the slides are already provided. Just one point on this next case I did want to mention was I don't think we need to really go there in terms of equivalency, and I know that's been a really complicated topic that we've gone through before at other sessions, but basically if you go through the slides, I don't use equivalency. I just start with 1 gram a day, and that's usually going to buy a patient about 3 to 6 bottles of oil per month, which is a pretty good starting point instead of getting all wrapped up in the math in terms of converting. But if anybody has questions on that, I'm happy to answer that later. And then case 6, we've already talked about the sativa kind of indica misnomer, but this is the case that I'd like to mention. So this is a patient in our clinic, and this is a significant adverse drug event that I wanted to highlight. I know it may not necessarily have a direct plant correlation as such, but in the interest of those in the room and Health Canada and reporting and safety. So this is a 32-year-old, actually, sorry, I think she's 36. She came to us with anxiety. We actually didn't know that she had a pre-existing history of bipolar, which we'll later find out. She also has Lyme disease, interstitial cystitis, ADHD, anxiety, depression, and insomnia. She's tried a number of medications over the years. And, now in hindsight, going back, I've spent a lot of time on this case looking at her PharmaNet. So PharmaNet in BC is a printout of all the prescriptions that have been filled, and it is a centralized system, so it doesn't matter where she fills them, we can find that out. What we did wrong was we only looked at 2 pages, and when somebody's filling prescriptions so closely together, you may only have a couple days or a couple weeks and not really see the full kind of breadth of the situation. So she was on a diazepam taper. After 10 years, they've been trying to bring her down, tapering 1 milligram per week. It was by a psychiatrist. And when she was hospitalized, she was at about 7 to 10 milligrams of diazepam a day. She was also on quetiapine as needed for anxiety, 50 milligrams 3 times a day, and bupropion, a pretty decent dose at 450 milligrams a day. And she also had these interesting suppositories, and she clearly had a lot of pelvic pain issues. So our plan, this is a pretty typical plan we would start in our clinic, 2.5 milligrams of THC at bedtime, and then increasing by the same every few days until desired effects. So this was for sleep, and targeting about 10 to 30 milligrams at bedtime, and in the daytime starting 5 milligrams twice a day, sometimes 10 milligrams twice a day, and increasing at a similar rate. Some patients find 50 milligrams is enough, and then others may need a couple of hundred. So we gave her the typical recommendations, printed them out on a strain recommendation form. However, she ended up over the next 7 days taking the full bottle of THC. So she took 1,000 milligrams of THC over a period of 7 days. And the story is really confusing if she was getting benefit, and so she just ramped it up on her own accord, whether she just, was potentially not in a good place, and if this was an intentional overdose. Her mom made a comment that because it said 1 gram on the authorization, 1 gram of dried product is 1,000 milligrams of dried product is 1,000 milligrams of THC. Perhaps she made that assumption. So we still don't know, and she's still in hospital, unfortunately. So basically, she presented in a THC-triggered bipolar state. So she was definitely manic. They didn't think that this was the benzodiazepine withdrawal. She was given a lot of neuroleptics to control her, and then she converted into an acute catatonic state. She could barely protect her airway. She was almost intubated a number of times. She could open her eyes, and that was it. And the tips of her fingers she could move. Nothing else she had control over. And so the psychiatrist, his comment to me on the phone was, it's like an NMDA syndrome, if you've ever seen that, which I haven't. And he actually was very concerned, and within the next couple of weeks wanted urgent ECT because he was concerned that this was life-threatening catatonia. So anesthesia was not comfortable, and they didn't go ahead with the plan, which was probably for the best because it took some time to declare itself. There was concern she was having seizures that were not being captured. This was in a small community hospital. And then I got some of the results. So the lumbar puncture was bland, the MRI was normal, CT head was normal, CT chest abdo-pelvis was normal. There is a paraneoplastic syndrome that it usually is presenting. We've had 3 in Vancouver in younger females, ovarian cancer related. And so it's this NMDA antibody that they can have. And so she did not have that syndrome that we were worried about. Her tox screen was positive for THC, which wasn't surprising. Unfortunately, it wasn't quantified. So in impairment cases, they will give you a quantity, but in the hospital, what I've seen a lot is just positive or negative. She was also positive for benzos, but that obviously wasn't too helpful either. She was started on Dilantin because they did initially, the neurologist thought she had some non-convulsive seizures. However, I've spoke to the epileptologist since, and there was never any documented seizures on any of her EEGs. So she had been in the ICU for 2 weeks when I heard about this, and so we had her transferred to a bigger center. She had been on Precedex is kind of the easiest way to say that medication, but it's a really intensive delirium medication we use in the IV form in ICU. And after 2 weeks, she was still really catatonic and pretty much like fluctuating levels of consciousness and not conscious all of the time. And so not even like a delirium where you're actually awake at least. So this was very concerning, and it was continuing. So when they transferred her to one of the bigger hospitals, she seemed to wake up a bit. So we're about 30 days out now. Her urine drug screen is still positive for THC, but she's actually moving. She's in 4-point restraint, but she's very delirious, and she's psychotic at times and repeating what the physician says to her. And this is somebody who was a primary school teacher before, so definitely this is not her typical nature, and it's been very distressing. And they are mixing up her medication slowly, but really one medication at a time, since obviously just too much could actually make things worse. And so, I mean, I've got some questions here, why did this happen? Or was it a mistake on the label or our authorization? Or, she may just have wanted to take all of that medication. And really, one of the highlights, I think, is this is a terrible situation, and we hope that, with recreational, potentially, coming in July or approximately, I hope we are not seeing more of this, but the more people are using cannabis, I mean, those risks are there. And so just to highlight, though, the therapeutic index, which I think is really important, as bad as this is, she took 500 times our recommended dose, and she didn't die. So she's definitely got severe adverse events. But as you can see from the diagram here, cannabis is very forgiving. So in terms of that window for how much for benefit versus how much for harm, it is quite forgiving. And then this was an article I just wanted to mention that we were using in terms of choosing her sedation. And these 3 case reports for patient young, actually kind of 20 to 25 years of age, these patients who were psychotic from THC resolve within 2 to 4 hours of using this dexdomitomate, I can't say it properly, and they resolve quickly. So she's been on it for almost a month and still hasn't resolved. So certainly this is not a usual case. And again, wanting to remind people that we need to be reporting these cases. So we will fill out this form once we get a bit more of an idea of what's gone on, so that we're aware going forward, we need more information on adverse events. And I've shared the link here, so it's a little easier to find, and it's 2 pages, and it's easy to complete online. And I may just hand it over to see if, any thoughts or comments.
Just in terms of the labeling, I'm not sure someone is confusing 1 gram dose and this equivalency in oil. I mean, that seems to be fairly unlikely, but so I don't think, and that's not occurring frequently, I think, with this kind of confusion. So, that's just a comment, obviously not a science explanation at all.
Yeah. I also get a lot of many patients who do confuse 0.67 grams, meaning 0.67 milliliters of oil. I also want to reinforce that given the fact that cannabis, although having a very high therapeutic index, does cause serious adverse events in some patients is one of the reasons why, as medical professionals, we really have to be responsible when authorizing cannabis and do our due diligence in screening our patients for previous psychotic illness, bipolar disorder, and provide the proper counseling.
Absolutely.
Just a comment on the adverse drug reaction. I think this is worthwhile submitting, even not having the complete resolution of the case, because you can submit and then transmit additional information later on.
Oh, so submit anyway.
Yeah, I would do that because, you know, as the way we are very busy, sometimes things get missed, and I think this is a potential important information. So if you are not submitting it to the regulators, they are not catching it. And sometimes you have those, one case is submitted, then there is an announcement of a potential risk, and then other people realize, hey, I had seen something similar.
Yeah.
And so I think it's worthwhile because there is an under-reporting of adverse drug reaction.
Thank you.
Okay, I can see a few hands up, so I'm going to do my Montel Williams thing and run around with the microphone. But we'll need to stop in about 2 minutes, so we'll try and keep it fairly short.
Very quickly, I'm sure this was done, but was an angio, CT angio, MR angio done, and then was there a urine drug screen done? Anything to suggest co-ingestions of any other products?
Oh, so the
Was
angiograms?
intentional. Yeah.
I'm not sure if angiograms were done, but certainly urine tox, serum tox, like all those. I just said the most relevant was just the THC and benzos. There was no other concerning opioids or anything of that nature.
There we go, Shane.
Just a quick point. This was an LP product that was
Yeah.
consumed.
Yeah.
By law, that should be reported back to the LP, and the LP QAP has a responsibility to do a full investigation, do the full ADR, and report to Health Canada, and keep that on record for annual inspection as well.
So I would do the form as well, and then the LP will also do their own form? Okay,
This is an interesting point.
okay. No, I'm just curious if it's going to be a duplication of the same incident.
It's an
Just want to
interesting
make
point.
sure.
Go ahead, John.
I just saw Hanan had his hand up, probably in response around that Health Canada.
All right, and then I'll come to you. I'll just take this question and I'll come back.
Well, I just wanted to point out, which is, I guess, obvious, but when I have seen cases, it's always with oils because people can take too much, and then the effects are much more lasting. I think at least with the vaporized products, they can't get into a situation like this because it would act too quickly. So that's certainly a risk for the oils, I think.
Yeah. Good point.
Thank you. I'm coming over to Hanan.
Just very quickly, thanks, Mark. Just to echo Shane's point that when a licensed producer, so under the regulations, a licensed producer is obliged to report a serious adverse reaction. They don't have to report all adverse reactions. It's serious adverse reactions, and there's a definition for that. Typically, it causes hospitalization, a whole bunch of other things like life-threatening, death. It's very, very serious. Within 15 days of becoming aware of the adverse reaction. So there's a time, there's a clock,
Okay.
in a sense. Anyway, and you can submit.
Okay as well.
There's no limit to how many reports you can submit. So you can submit, the licensed producer can submit, and we'll
Okay.
just sort of collate the reports together.
Perfect.
Yeah. Thank you, Caroline.
Thank you.
Okay, we'll just take maybe one more comment, and then I think we need to stop and take a break for...
This is just a comment on this case, which was presented in a flurry of emails on PMCR, and I would encourage everyone here who's interested in prescribing cannabis to join Physicians for Medical Cannabis. It's a very active group, including Ethan Russo and many other learned contributors. And you can join by just emailing pmcraccess@gmail.com, and it's a wonderful forum, lots of CME material. But my take on this discussion through that was that there was some question about whether this really was a THC phenomenon and whether it was perhaps a ketchupine reaction, whether it was more related to NMDR, antibody production, autoimmunity.
So we're still waiting on, there's that antibody, the vasculitis autoimmune panel that's been sent off. There was consideration for pulse steroids and IVIG, considering if that could be the case. They're fairly certain now this is presenting as THC psychosis, precipitated psychosis.
Quite a bit of divergence of opinion there, isn't there?
Yeah.
On the dialogue online.
Okay, please join me in thanking Caroline, Daniel and John.